that, and sorry, you can always listen to that and answer that, and we'll mark your attendance that you are present. Thank you so much. And once again, very good evening. It's my pleasure to introduce. Can you all see my screen? Yeah. Can you all see my screen? Sorry. Yeah. Yes. So it's with great pleasure. I would like to introduce Dr. Pankaj Singhai. Thank you so much, sir, for taking out your time in spite of your busy schedule and having you with us here today. We heard a lot about you on renal palliative care, that you are such a great speaker, and thanks a lot. So just to give a bit of background, Dr. Pankaj Singhai, sir, has done his MBBS graduation from GR Medical College, Gwalior in 2013. And sir has completed his MD in palliative medicine from Tata Memorial Center, Mumbai in the year 2017. And sir worked as a senior assistant in Tata Memorial Hospital, Mumbai from 2017 to 2018. And sir is currently working as an assistant professor, Department of Palliative Medicine and Supportive Care, Kasturba Medical College, Manipal. And sir is one of leads renal palliative care clinic at Kasturba Hospital, Manipal. Thank you so much, sir. Having you with us today is a great, great to have you. And over to you, sir.
Thank you so much, Vanilla, for giving me this opportunity. I'm really delighted. And welcome you all. Greetings from India. I will start my screen share. 1 minute. Can you see my screen?
Yes, sir.
Yeah, thank you.
Can it become a little more zoom out, sir? Is that possible?
Don't you
yeah,
know?
No. That's enough, sir. Let it be like that. Yeah.
Okay. So today, as Vanilla told, that we will be talking about palliative care in non-oncological illness. So I will be talking about palliative care, how palliative care can be integrated into patients who have kidney diseases, various kidney diseases. This is a bit new topic in palliative care. But in last 10 years, there's a lot of research, lot of clinical activities it's going on in this field. People has realized that apart from cancer, neurology, heart failure, there is a significant need of palliative care in these population also. Patients of CKD and other renal diseases, they may require some sort of palliative care during their disease, their treatment, or for end-of-life care need. So I will be talking about a few points. One is basic nephrology that we all should know as a palliative care physician. I forgot to ask whether all of you are working in palliative care already, or it's the first time you are undergoing some course in palliative care.
Yeah, I think, sorry, sir, I missed mentioning that. All these doctors and nursing officers are working in different hospitals and district hospital others. They are very new to palliative care.
Okay, all right, yeah. So
yes.
All of us are almost like very new to palliative care, but it's good that you had some interest in palliative care. So, during in our clinical practice, we all see patients with renal functions. Many of them are they have chronic kidney diseases also, and I believe all of you must have seen patients who have CKD, terminal chronic kidney disease, or another word, end-stage kidney diseases. They might be on the dialysis or not on dialysis. So we will talk what the basic nephrology that everyone who is working in palliative care should know. And then specifically in CKD, what are their suffering, what symptom burden they have, and then how we can provide a better symptom control in these patients. This is about those all patients who may be on dialysis, not on dialysis. Then who are those patients who need an extra layer of support, extra care, that is kidney supportive care, how to identify these patients. And in some patients who choose that they do not want dialysis when they are terminally ill, how can we provide conservative management for that patients? And one questions that comes to every patients and clinicians also, that whether the dialysis is absolutely required for all these patients. So and if at all the withdrawal from dialysis can be done or not. Okay, so
someone, sorry to interrupt.
Yeah.
Dr. Tanujan has raised your hand. Do you have any questions?
No, ma'am. Mistakenly.
Okay. Yeah, please go ahead. Sorry.
Yeah. So I will just go to very brief into the nephrology. So what is chronic kidney disease? So any renal disease that is more than a few weeks or months, there are multiple definitions, but the standard, there are 3 weeks or more than that. If there are deranged renal functions, or if patients are at risk, that is called as chronic kidney disease. For our interest, basically when their creatinine falls down, then we call it as kidney disease, and if it is for very long time, it will be termed as chronic kidney disease. Okay, and there are 5 classification. Basically, for most of our practical things, any create clearance more than 60 is good for us. But these patients, even if their creatinine clearance is more than 60, they may be at risk of having renal injury. So it is important to identify these patients who are at risk or with minimal deranged glomerular filtration rate. Any patients whose create clearance is less than 60, that may be stage 3, 4, or 5. So if it is from 30 to 59, that will be moderately decreased GFR or stage 3. If it is less than 30, then it will be termed as end-stage renal diseases, ESRD. Okay, most of the patients whose create clearance is less than 15, or who have features of uremia or complications because of urea accumulation in blood, they may require dialysis. So dialysis, I think all of you know that it's of 2 types. Either they may opt for peritoneal dialysis or a routine hemodialysis, where they are connected to a dialysis machine and the toxins are removed from the blood. Okay. And then we all know that the kidney is important for excretion of many drugs, and there may be some drugs that may affect renal functions also. So everyone knows that NSAID is, if it is used for long term, can cause kidney damage. There may be interstitial nephritis or glomerular damage. And that's why we should not use NSAIDs for very long term. And we should be cautious when we are using NSAIDs with proper hydration and for a minimal period of time. Aminoglycosides are some other drugs, antibiotics that can cause renal damage, and these are amikacin and gentamicins are very commonly used in our setups. In palliative care, especially in patients with cancers who have cancer spread into the bones, in those patients, bisphosphonates are used, especially CA breast, CA prostate, multiple myelomas. These patients are on bisphosphonate, commonly zoledronate or evandronate, and if it is not used with proper hydrations, this also can cause some glomerular damage. That's why we need to check the creatinine in these patients and always give it slow with good hydration. Some chemotherapies, like commonly used cisplatins, can lead to deranged renal functions. Sometimes some antihypertensives like ACE inhibitors, ARBs, and diuretics also, they may cause some derangement in renal functions. But this is a very gray zone. We need to be very careful when we start or we are stopping that time. So at that time, the experts, physicians' opinion can be taken about ACE inhibitors, ARBs, because these drugs also used in patients with CKD, because the ARBs can be renoprotective. Also, diuretics can help in decreasing the volume overload. But if it is not used properly, these can affect the renal functions also. And many times there are people are on alternate system of medications, and that may have some damage on renal function. So we need to check if a patient is on some alternate medications also. Apart from that, as we know that some of the drugs or their metabolites may be excreted through the kidney. So I think all of you by now, you know that morphine should not be used if there is deranged renal function, or if at all we need to use, we should use it in lesser dose and more prolonged interval also. Similarly, for tramadol and tapentadol also, we should use a smaller dose and with more gap, so that patient doesn't have the toxicities of these drugs. If we talk about the alternates, so fentanyl and methadone are safer drug which can be used in these patients. Similarly, there are antibiotics, some OHAs for diabetes, and these like glibenclamide or metformins. These again depends, they are excreted to the kidney, so we should avoid. Gabapentin and pregabalin, these may cause more toxicity, more drowsiness in the patient if we use the same dose what we use in neuropathic pain in CKD patients. It may lead to higher degree of drowsiness, dizziness. So that's why we need to decrease the dose, increase the interval and all. And sometimes lithium mirtazapine, also we need to be careful. We can use safely phenytoin, carbamazepine in these patients. Also, haloperidol can be used safely in these patients. So it's very difficult to remember which drug can be used, or what drug modifications we need to do in these patients. So now in the world of internet, we can easily see the drug dose modification. Either you can go to Medscape, or I have shared this link, which is American Association of Family Physicians. There they have given very clearly which doses we should use at what clearance. Creatinine clearance, we usually use the common formula that may be Cockcroft-Gault formula. That's very easy, and you can use either calculator or by just simple calculation. But we need to be mindful, especially if in palliative care patients, where we can see their side effects very early, and they may be on multiple medications. So check their creatinine clearance, and accordingly we should give the doses. Okay, it is mainly for the maintenance doses. Maybe the loading dose we can give safely, the standard dose we can give for antibiotics or even for opioid analgesics, but maintenance dose we need to be more careful. Okay. And then about epidemiology. So we know that in our region, the diabetes is very, very common, and diabetes is the most common cause of CKD. Most of these patients, they developed diabetic nephropathy, and that leads to end-stage renal diseases also. And that's why as diabetes is very common, and it is many times it is undiagnosed, that leads to high number of CKD patients, and they may have very high symptom burden, because kidney diseases are not just it's not a disorder of kidney. It is a systemic disease, and that they may have a very high symptom burden. For CKD, the standard treatment is renal replacement therapy. That means either transplant or hemodialysis or maintenance dialysis in these patients. Unfortunately, a lot of patients, they either cannot afford transplant, or they may not get donor, or they are not fit for transplantation, and they are on dialysis. And most of the time, this dialysis is not it's not a bridge to transplant. It is a palliative measure to reduce their symptom burden. And unfortunately, almost 50% of them dies while they are on dialysis every year. Okay, so and if their age is more, if they are elderly, if they have some comorbidity, the mortality increases many times. Okay. What we see in India, that most of the dialysis centers are run by dialysis technicians. Okay, so what dialysis technicians do, their job is to connect the patients to the dialysis machine, and to ensure that the proper dialysis is happened. But they don't have access to the nephrologist who can actually maintain a good symptom control and other manage other problems also. So now most of these patients doesn't have continued access to nephrologist, and that's why we see that in our region the symptom burden is much higher, and they have a higher morbidity and mortality while they are on dialysis also. If we currently, this is a report published in Lancet, that CKDs are 16th most common cause of death currently, but it is expected that by 2040, seeing the increasing prevalence of CKD, it will be the 5th leading cause of death in overall worldwide. We will have higher needs of palliative care, and there will be increased population, such population. So we need to aware of managing these patients and providing a good symptom control in these patients. In India, if we see, a lot of patients, they are undiagnosed with ESRD. Even those who are recognized as ESRD, they don't have access to renal replacement therapy. And even those who have access, who gets dialysis, they do not stay, mainly because they may not have the logistic, they may not have the financial support, may not have good familial support or social support also. And because of symptom burdens also, a very few of them actually receives the maintenance dialysis or renal transplant. So if you see in the, apart from the red, apart from the green area, all these area, they majority of them, they need some sort of some sort of palliative care support. And that's why if we integrate it better, we may be able to provide them even good nephrological support. If their symptoms are controlled, they may be able to continue the dialysis, or we may bridge the crisis situation pre-transplant or after the transplant situations. Okay. Sorry, there's something happened here. Okay. And this is on the trajectory of illness. I think you might have seen already. In cancers or other chronic illnesses, there is some trajectory of illness that most of the patients they go through. So in cancer, if you see cancer, this is it is given for colon cancer here. They may have a preserved quality of life or preserved functionality for most of their time, but once the disease becomes metastatic or progressive, their quality of life suddenly drops, and they live for very short period of time. Okay, and and that's the time where most of the time the patients are referred to palliative care. But in patients who have non-oncological illness, the trajectory is not same. At the time of diagnosis only, their functional ability may come down significantly, and they may be it may be preserved for some time, but there may be some acute crisis situation, and at that point of time, if we provide some support, they may also go back to near normal, near previous quality of life. But these patients are at the risk of multiple such crisis situations. So it becomes very difficult to predict the prognosis in these patients, whether some aggressive interventions may help or not. And at that point of time, integrating palliative care, identifying their needs, and the goals of care, talking to the families, talking to the patients, may give us more idea what the patients want and how the care should be provided. Here I have added one more trajectory that is in the red color, where those patients who choose not to go for dialysis, what trajectory they may have. Especially in patients who are elder morbidities, it has been seen that there is not much significant benefit of giving dialysis on the overall survival. But if we see, their quality of life can be preserved for majority of their time, because they need not to go to a hospital very frequently. They may not they are not on very aggressive interventions. They are not in ICUs and all. And that's why if we provide a good supportive care to them, they may live for a significant time with a preserved quality of life. Please note that I am talking about those patients who are elderly and they have significant comorbidity. I'm not talking about those patients who have preserved functionality, or who are young and who may get benefit from renal replacement therapy. I will talk to you about that later also. So what are the treatment options when we see patients with CKD? So first and foremost is correct the correctable and slow the progression of disease. So for slowing the progression, we need to diagnose them early. And when we are diagnosing them, try to identify what is the reason why this patient has developed CKD. We need to correct that reason. Most of the time it is either diabetes or hypertension, so that we need to treat adequately. Along with that, because these patients may have proteinuria, and the kidney may not be able to handle the protein load, so we may have to give the protein restrictions if they are not on dialysis, give them a low protein diet. And we need to adjust the medications doses according to create clearance, so that there should not be further kidney injury. Then there may be complications like as pulmonary edema, there may be electrolyte imbalance, there may be anemia. Multiple complications can be there because of CKD, so we need to treat those things. Then third option comes is renal replacement therapy. So as I said, there may be either hemodialysis or peritoneal dialysis as a dialysis option that is usually a bridge to transplant. A patient is a candidate for transplant. Patients, after receiving some days of dialysis, patients may receive transplant, and sometimes there are transplant failures and all, and then again patients may go back to dialysis. And the other option could be the comprehensive conservative care, that is the supportive care or palliative care in these patients. That is for those patients who choose that they do not want to go dialysis, or they feel that dialysis may not be useful for them, especially those, as I said, that very elderly people with multiple comorbidities, poor functional status. In those patients, a conservative care approach may be used. Along with the treatment part, we need to provide them a good symptom control in these patients. And if the disease we are not able to control and patient is at terminal stage, we need to provide a good end-of-life care in these patients. Providing end-of-life care also can be very challenging in these patients, because at that point of time, there will be dilemma whether to give the dialysis to these patients, or what drugs we need to give, like very commonly infusion of morphine is given to provide pain control or breathing difficulty, and such drugs may not be given in these patients. So it can be challenging, but we will discuss what can be done for these patients. Okay. Apart from these treatment, because it's a kidney diseases are not just a kidney disease, it's a multi-systemic disease. They have a lot of problems, there are a lot of complications, and the treatment is very expensive. One has to go dialysis at least a week, and that is itself a costly, and these patients are on multiple medications. They need to travel long distance for these to access this treatment, and this can cause a significant expenditures for the patients, and for many of them, they may not be able to afford these things. I had seen many people who were receiving dialysis for a few years, and sometimes they had to stop dialysis because they were not able to travel, or they were not able to bear the expenses, and the government facilities were not available. Nowadays, there are a lot of philanthropic trusts. They have started dialysis treatment, or government institute in India. They are providing it at the district level. But yeah, there's a lot of other problems also. We'll talk next. This was about the epidemiology. We'll talk next about what are the suffering in these patients, the symptom burden. As I said, that CKD is not a single system disease, or just not a single end organ failure. It's a multi-system disease, and the kidney is not. The job of kidney is not just to filter the toxins or out, but it has a lot of other work to do to maintain the homeostasis. It does the electrolyte balance and the water balance in the body. It leads to elimination of nitrogenous waste. It causes erythropoietin production, that is very important for maintaining the hemoglobin level in our body. Also, it maintains the phosphate level in our body that is required for maintaining the correct pH, and also for the bone for the bone formations also. It also is needed for activation of vitamin D, that is required for proper functioning of the bones and calcium level. And other than that, the phosphate elimination is also required. So if there is any injury to kidney diseases, to kidney, it may lead to multiple side effect, multiple effects that we see clinically. There may be there may be multiple complications in these patients. So if we see the common complications, these patients are at risk of both bleeding and also the stroke. Patients with CKD, it's very common to have stroke in these patients, and it can be ischemic or hemorrhagic, especially in those who are on dialysis. Such events are very common. The kidney disease patients, they are at risk of developing ischemic heart diseases. They may have the pericardial diseases or pericarditis, or heart failure is very common in these patients. And these patients are immunosuppressed, and they are at risk of developing sepsis repeatedly, and that is true. A very severe sepsis they may develop. If they are on fistula, they have access for the dialysis, the fistula failure is very common. Some of them, they develop the pancreatitis, and that leading to persistent abdominal pain. There may be crisis situations during the transplant, or before transplant, or after transplant. There may be many crisis situations for these patients where the patients can be very sick. These patients are prone for peripheral vascular disease and also deep vein thrombosis, and that sometimes leads to very severe ischemic pain, chronic ulcers, sometimes gangrene, and that may need amputations also. A bone disorder, as I said, they may have disorders on bone metabolism, and that may cause severe deformities in these patients. And the chronic pain is very common in such patients. There may be some bleeding disorders also. They present with UGI bleed or intracranial bleed. So these are all the complications that the kidney disease leads to. And these all complications leads to multiple symptoms in these patients. So the most common symptoms that we found in one of the study was depression, that is undiagnosed depression. They have persistent low mood because of the disease, or maybe because of the symptoms, because of the social reasons, and many times the clinicians fails to diagnose that, and they may not be able to get the proper mental health support for such patients. These patients develop anorexia, loss of taste, and the multisystem disease. All these things lead to cachectic stays in these patients. They may not look cachectic sometimes because of the edema they develop, but that is actually the cachectic stays they have, along with the edema and asarca they may have. They also have a persistent nausea or vomiting because of the increased urea level, and sometimes it can be very severe also. Again, accumulation of fluids into the lungs, or increasing preload into the heart. These all things can lead to breathing difficulty. These patients are they have chronic anemia, also persistent anemia, and these all things lead to breathing difficulties. Developing multiple infections, chest infections may also cause breathing difficulty, cough. They may have recurrent abdominal pain, especially in patients who are receiving peritoneal dialysis, because the chances of peritonitis are more common. Or maybe they may develop the secondary malignancies or pancreatitis, and that is leading to recurrent abdominal pain. Some patients who have polycystic kidney disease, that also can cause persistent abdominal pain. Apart from that, very common symptom is persistent itching, severe pruritus, restless leg because of iron deficiency, anemia, or anemia. That is very bothersome for these patients. And these all things collectively, it leads to the persistent pain and suffering to that patients, to what Cicely Saunders used to call the total pain, and that is a high prevalence of such symptoms in these patients. In one of the study, it says that the suffering in patients with chronic kidney diseases is as similar and significant as in patients with advanced cancer. And for these patients lives with all these symptoms for very, very long time, all years together also, and they suffers with these symptoms. So that's why there is unmet need of palliative care in these patients. This is one of the study that we did last year in some of our patients who are undergoing dialysis. This is a study of in the patients who are receiving dialysis in our tertiary cancer center, where they have access to the nephrologist, good team. And still we saw that the symptom burden was quite significant in these patients, and there was multiple unmet need in these patients. You can see that half of the patients, they had pain. Fatigue was there in 2/3 of patients. There, almost 50% of them had sleep disturbances, itching, or 1/3 of them had some breathing difficulty. Apart from the physical symptoms, there was some other psychosocial needs also that was not met, and we felt like integrating palliative care in such patients may bring some improvement in quality of life, or some change in on the patients and family members' life. Apart from that, as we saw that the chronic kidney disease has many complications as such, but the treatment itself may cause some side effects, some complications, and that we commonly see in patients who are undergoing dialysis. They may have hypotension, they may feel the cramps when they are undergoing the dialysis, or sometimes headache, the vomiting is common, or they may develop some itching over the body, or fever. So these are complications. Some of them may have some effects, some may have some other complications and all, but most of them they develop they felt like some of these complications were there in most of the dialysis sessions. Apart from that, if the patients are on dialysis and not given a proper care, they may have the financial toxicities. The caregiver burnout is seen very commonly. There may be complications because of the fistula axis, or they are developing the side effects of these things. So how a good symptom management by palliative care physicians, or those who are learning, those nephrologists who are focusing on symptom control, can provide some more distress relief in these patients. So I will talk about symptom management. Till now, if any one of you have any questions, I can take those questions. I'm sorry, I'm not able to see the chat box.
Right now, there are no questions in the chat box, sir. Requesting all the participants to put your questions either in the chat, or you can just please unmute your microphone and please ask questions.
Is it okay if I can take 5-10 minutes more also, because I got to know that today's second session is cancelled. Is it okay if I?
Yes, sir. That's all right. Yeah, that's all right.
Thank you. Yeah. So symptom management, as we saw that there are quite a symptom burden in these patients. So we need to go more aggressively in these patients. So this is a case story of one of the patient which I saw a few weeks back. He was elderly man. He had diabetes since many years and was diagnosed with CKD 5 years back. And after that, he was on dialysis for around 4.5 years. He was receiving twice weekly dialysis, and he was doing okay for a few months. Then he started developing the persistent itching, some itching all the time. And sometimes he said that it was so severe that he felt like it's better to die with rather than itching all over the body. And it was very, very severe for him. He also had diabetic neuropathy, and he used to complain that there are burning sensations all over the fits, and it's also persisting. We see a pain very commonly in these patients. In our study, it was around 50% they had pain. Most of the time, it is either musculoskeletal pain because of the bone deformities, or sometimes it is neuropathic pain that may be because of the peripheral neuropathy, because even the dialysis sometimes can or CKD can cause peripheral neuropathy. And apart from them, they have already the diabetes that can cause diabetic neuropathy. The neuropathic pain and also musculoskeletal pain is very, very common in this patient. Some of them have the ischemic pain, that is, they are maybe because of the peripheral vascular diseases. And if that pain is there, that is usually very, very severe. So how can we manage pain? So we follow the same principle what is there for any chronic pain, that may be for the cancer or non-cancer illness, the principle of chronic pain management. And for that we use the WHO ladder. The steps are same, but some medications may be changed. So like we do not use codeine or morphine as much as possible in CKD patients, and NSAIDs are usually avoided in these patients because these may further worsen the renal functions. It can be used, NSAIDs can be used in the end-stage renal disease who are on dialysis or not. For very short term, if other measures are not helping. So if any patient is having severe musculoskeletal pain, and if the opioids or other adjuvants are not working, then we can use NSAIDs for a short period of time. If they don't have any other preserved renal functions, like those patients who doesn't have any urine output, in those patients we can use, but at best we should try to avoid NSAIDs. So this is the WHO step ladder. The step 1 is for mild pain, where we can use paracetamol. Paracetamol can be used up to 4 gram safely. And with that, we can use adjuvant analgesics depending on the cause of pain in these patients. If it is not controlled with paracetamol, we can, or if it is a moderate pain, then we can go to step 2, where we uses weak opioids. We avoid codeine because it is converted into morphine metabolite, and that is not excreted through kidney. So we can use tramadol or tapentadol safely, but usually start in low dose. So we can start with the commercially available 17.5 mg or 25 mg tablets that we can use. Instead of thrice or 4 times a day, we can start with 2 times a day and SOS, and then slowly we can increase up to 100 mg per day. We can safely use in those patients who are on dialysis or also not on dialysis, in both patients. Then in step 3, we should avoid morphine at best. If there are no other alternative, then we should use minimal possible dose of morphine. So maybe 5 mg tablet that we can use twice a day or thrice a day in such patients. But if other alternate like methadone, fentanyl, or buprenorphine is available, then that would be the safer options in these patients. So fentanyl, either as IV or as a transdermal, we can use safely. You start with lowest possible dose because even if it is safe in renal diseases, there are chances that some accumulation can happen, and that can lead to increased drowsiness in these patients. So a minimal possible dose, and slowly we can titrate accordingly. The methadone is also safe, and but we need a more careful titration by the expert. If we talk about the adjuvants that are used, as I said previously, pregabalin and gabapentin, that they can use, but these are dependent on renal function, so we should start with a smaller dose. For pain, I usually start either 50 mg of gabapentin or 100 mg of gabapentin. Alternate day I start, and then slowly we see for 3 days or 1 week, and then we increase the doses slowly. For pregabalin, I usually start with 25 mg, that is now commercially available, and usually after dialysis, if patient is on dialysis. If not, then twice a week we start with, and then slowly we go up, because what we had seen that chances of drowsiness is more common in patients with end-stage renal diseases. Other medications for neuropathic pain like carbamazepine or valproate or phenytoin are relatively safe, but may not be that effective in CKD, but yeah, these can be used. Talking about TCAs, so TCAs also can be used, but the chances of side effects are more. So again, we should start with lowest possible dose in these patients with more gap. One thing we should be always, we should remember that these patients have pain for very long time, and sometimes they may not tell you because of the fear that the pain medications will further cause derangement of renal functions. So we need to assess them more proactively, ask them, do you have pain, do you have severe pain? And if they say yes, they have pain, we should give them a good pain relief. Then other common symptoms is pruritus. So one thing about pruritus I would like to tell that it is uremic pruritus is usually not histamine independent. So giving any antihistaminics may not help. That's why the commonly used like Allegra or levocetirizine, those things does not work in most, or Atarax does not work in patients with CKD. What we had seen, what works actually is using a good moisturizations, avoiding the repeated scratching and all. Sometimes phototherapy can help. And talking about the pharmacological measures, then using pregabalin or gabapentins, it actually works. So the highest level of evidence is for gabapentin or pregabalin. Then there may be the sertraline or thalidomide can also be used in terminal stages in these patients. Then other common symptoms is restless leg syndrome. So restless leg syndrome is most common cause in these patients is because of iron deficiency anemia. So we need to look whether their iron level is correct or serum ferritin level is correct. And we should treat them with intravenous iron. Sometimes because of hyperphosphatemia also, or maybe because of some drug interactions also, there may be restless leg syndrome. So those things need to be corrected. If there is any medications that is leading to such symptoms, that should be avoided. What drugs that can be used in these patients? So vitamin C and vitamin E supplements, that these are helpful. Gabapentinoids again have been found to be helpful, or the drug that is used in other elderly people with restless leg syndrome, that is rotigotine or pramipexole in a very small dose, can be considered in these patients with restless leg syndrome. Nausea, vomiting, as I said earlier, that it is very common because of uremia. So if we can correct the uremia with dialysis, we can opt for that. if any drug is there, like a tramadol or other opioids that is leading to nausea, vomiting, that should be the dose should be reduced or can be stopped. Some of the patient, they develop because of uremia, they may develop the gastroparesis, and that can cause more constipation and nausea, vomiting. In those cases, we can use prokinetics. So metoprolol can be used, but in reduced dose. So usually half dose, we can use 2.5 mg or 5 mg we can use. Ondansetron, at the best we should avoid, but if it is related to some cytotoxic drugs and all, we can use it. And then haloperidol and olanzapine is found very useful in patients who have uremic nausea, vomiting, and in a small dose also, like 0.25 or 0.5 mg, their nausea can be controlled in these patients. But because these drugs works through the dopamine receptors, again we need to be more careful about about the restless leg syndrome in these patients. Dyspnea or breathlessness, as I told, that it is very common, maybe because of anemia, infections, or fluid overload, sometimes anxiety. These all things can cause persistent dyspnea or severe dyspnea in these patients. So those non-pharmacological measures can be used. In patients who are progressing toward the terminal disease or end-stage renal disease, who may have very few expected few weeks or few months of survival. In those patients, also we can use fentanyl, the opioids. So fentanyl, either it can be used as a transdermal patch, or sometimes if it is available, you can use the OTFCs also as a measure to reduce the dyspnea. So that is the difference in non-renal patients where we use morphine usually. So apart from, instead of morphine, we can use fentanyl in these patients. And some of the studies, although we don't have many studies, but some studies has shown that fentanyl is as effective as morphine in terminal diseases. If patients is have a few hours or few days of expected survival, in those patients we can also use morphine also, because in that case the accumulation may not be that much over the days and all, and we can use morphine to reduce the sensation of or awareness of breathing difficulty. So in one of the case, we had used morphine, and she was with us for around 4 and 5 months altogether. And we started with very small dose. We have our pharmacy practice department, they give even 0.5 mg of morphine. So we started 0.5 mg before dialysis, a day prior to dialysis, because she used to develop breathing difficulty before dialysis. And that helped her in reducing dyspnea along. But usually otherwise fentanyl can be used as in such cases. Depression, as I said, it is very, very common, and many times it is not diagnosed also. So we need to look for depression, and we should give a proper mental health support and treatment to these patients. Then at the last, I would talk about how we can identify patients who may require renal supportive care. Vanilla, how much time do we have?
You can go ahead, sir, for another 5 minutes.
I'm sorry?
You can go ahead for another 5-10 minutes, sir. No problem.
Yeah. Okay.
Yeah.
So quickly we will go through our next case. So I had one patient, 85-year-old female. She was on dialysis for many years. But since a few years, she was telling that the nephrologist has suggested that she needs some thrice a week dialysis, but she said that I'm not able to afford the extra dialysis. And but the problem was because of heart failure, after 1 day of dialysis, she used to feel the breathlessness and severe pain all over the body. She had support from their children, but as such, she doesn't want to be a burden on them. So there was a lot of psychological burden in this patient, as also physical burden. So we had a family meeting with their children. We could not involve the patient herself, but on behalf of patient, we spoke to the family, and the family also felt like she is suffering for a very long time. And at this point of time, our main intention should be to make her comfortable as much as possible. So during one of the dialysis, she developed severe angina and she was breathless. And at that point of time, all the family members decided that from now onwards, we should not subject her to dialysis, because even dialysis also is causing her more pain and because of hypotensions and all. But their main concern was if we stop dialysis, she will become more breathless, and they don't want her to become breathless. So at that point of time, we had a meeting with them, and we ensured that we will try to reduce the breathlessness as much as possible with all palliative care measures. That patient was with us for a few days, for around 5 days, and she passed away in very peace, and the family members were satisfied that at the end she didn't had any suffering. But the problems comes like how we can identify those patients where the supportive care can be provided. So there are some guidelines. One of the guidelines that we found it very useful is proactive identification guidelines by the NGSF. So one questions that you can ask is surprise questions, that whether the nephrologist would be surprised if the patients would die in next 1 year or few months or few days. If they say no, that patient is eligible for palliative care. There may be some general indicators like repeated hospital admissions, advanced diseases, multiple comorbidities, like those poor performance indicators, if that are there. And that is one of the indicator. Then there may be some specific indicators related to kidney diseases, like if the patient is not tolerating dialysis, or sometimes the patient themselves is choosing no dialysis option, or their symptoms are increasing day by day, and that is not controlled with normal measures in those patients, and these are eligible for palliative care. One of we don't have many identification criteria, but one that one scoring criteria they had found it useful is about the prognostication score for the 6-month mortality. It was in patients who are more than 75 years of age. So if they have these presence of these indicators or risk factors, then these patients may be considered for conservative care or renal supportive care. Then last options comes, the last topic for the day was, can we consider withholding or withdrawal from the dialysis? So usually in the questions of physician comes like, if we don't this, aren't we reducing the overall lifespan of the patient, or aren't we that patients will die earlier? So there was one study that was done a few years back, although the sample size was very less. But in that study, they have found that those patients who had age more than 75 years of age and comorbidity, especially IHT, in that they found that there was no survival benefit in of continuing dialysis. That means those patients who opted for dialysis versus those patients who didn't opt for dialysis, both of them had overall same survival. So there was no survival benefit in these patients. But yeah, this study was of very few patients, so we need to have more research about such indicators, and if we can find out who are the patients who may benefit from dialysis and who may not benefit from the dialysis. So if we identify those patients who are eligible for or who should receive renal supportive care, or who are at their end of life care, what all things we should do. So one thing is providing good symptom control, having a good communications, finding out what exactly patient want, what the family members understanding, and what type of care they want. If a patient, they have more complications because of CKDs or their treatments, at that point of time, what type of care should be given, whether should be subject them to very aggressive interventions that may not be helpful. And also we need to identify their end of life care needs, what are the unmet needs in these patients, and providing a good psychological support also for these patients. So providing care during last days of life is very, very important. If we talk about end of life care, commonly what we see, the symptoms that we see in these patients is one is breathing difficulty. So breathing difficulty, as I spoke, the non-pharmacological measures or using opioids in these patients. If patients have some urine output or some preserved renal functions, using appropriate or high doses of diuretics also can be used. So even we use 40 mg thrice a day or 80 mg thrice a day of diuretics of furosemide, and that may help in reducing the preload or fluid overload in these patients. Other thing, because of uremia, patients may have seizures or may have hallucinations, restlessness, delirium. So using haloperidol or midazolam, those things may be used as those symptoms can be controlled in these patients. And one thing we need to be mindful that these patients, they deteriorate very rapidly because of fluid overload and uremia. So we need to be more proactive in providing the symptom control and ensuring that the symptoms are controlled at that point of time. So this was about in short about the renal supportive care that can be provided. If you want to read more about the renal supportive care, there is a very beautiful executive summary that was in Kidney International Journal in 2015. You can read, or maybe in Oxford textbook of palliative medicine, it also gives a very good idea. Recently, last month only, we had published one supplement in Indian Journal of Palliative Care, where each topic wise we had arranged the articles or review articles about the various aspects of renal supportive care. It's a very good document, and I think you may read about this thing. It is available on IGPC website, that can be read. So thank you so much everyone for patient listening. Yeah.
Thank you very much.
Yes, doctor, please go ahead. I think you have a question. Please go ahead.
I'm Dr. Jayara sir. Can you hear me?
Yes, sir.
Yes, yes.
Thank you for your detailed presentation. 3 months back, we had a patient with end-stage renal dialysis.
We can't hear you. Sir, we can't hear you. Can you just turn on your,
hello,
I can hear you.
Can you just turn off your camera and then speak, sir, if you don't mind?
Yeah. we had a patient with dialysis at the same time palliative care. Due to the increasing demand of the dialysis in Sri Lanka, we have limited services, dialysis services in Sri Lanka. So most of the time the patients, they have to spend their own money, or sometimes they might have a transport difficulties. What about in India for the dialysis services? Are the patients, they have to spend a lot of money for the dialysis, or the government services?
Yeah, so actually the same scenario we have in India also. We have dialysis facilities in government centers also. Recently, like the Prime Minister has offered that every district hospital must have the dialysis facilities. But at many centers, it is just on papers, or the machines are not working properly, or they don't have the proper staffs and all. At many centers, it is not working. But yeah, many centers, we have government facilities, and that provides free of cost dialysis to those patients. Apart from that, there are many trusts that give supports for dialysis, free dialysis, or they provide the financial support. But still, because of the high burden of the disease, a large majority of them are unable to continue dialysis, or they may not be able to do the dialysis. Many of them has to travel 50 kilometers or 100 kilometers every alternate day, or after 2 days to the dialysis facilities. So that may be very, very challenging to the patients.
Thank you so much.
And that gives us the need of palliative care. In such patients, we should be able to give them at least a good symptom relief, and that I think every general physician also should know. Because before coming into palliative care in my after graduations, I never knew about managing symptoms of renal failure. We all know what's the treatment for the dialysis, or managing diabetes or hypertension in these patients, but symptom control no one teaches. So we need to be aware about those things, and if a patient is in end stage, we should be able to provide end of life care in these patients.
Any further questions, sir? Any of the faculties? Sorry, any of the participants? If you cannot speak, you can just type your question in the chat. We'll read it for you. Sir, if we convert your presentation into PDF and share it with the participants, is that all right?
Yeah, definitely.
Thank you, sir. So if we don't have any questions, so shall we wind up the session for today? Shall we close the session for today?
Yeah, sure. Thank you so much, everyone, for joining, and thank you, Vinila, for coordinating this thing.
Thank you so much, sir. I should thank you for giving your time in reaching out to our participants. Thank you once again, everyone. So for missed out participants, like as I told last time, we'll be sharing the recorded YouTube link in a personalized YouTube channel, and participants, those who have missed the session or like are unable to join, like we'll share the link. Please listen to that, and we'll also share a couple of questions so that you can answer, and we'll mark your attendance. And thank you once again. We'll see you next Wednesday at 7 p.m. again. Thank you so much. And due to this, one of the faculties who are unavailable today due to unforeseen reasons, we had to cut short the session, and today we have only one session. Thank you once again, everyone.
Thank you
Thanks a lot.
Bye-bye. Bye.
Thanks a lot.
Please do not forget to share your valuable feedback. The link is there in the chat box.